and we will go to Greece. We have a very nice case from Dr. Georgios Mavrogenis. Is George with us?
Are you listening to us? We are live.
Hello.
Can you hear us?
Yes.
Hello. Thank you very much for the great honor. Here I am with Dr. Andreas Koutsoumpas and Ioanna, my expert assistant. We have a 75-year-old lady. Please put the presentation slide. It's a 75-year-old lady with a small diverticulum, 2 or maximum 3 centimeters in size. And the plan is to do Z-poem. I think Z-poem is excellent for small diverticula because with standard septotomy, we cannot be very radical. Although, let's agree that all techniques work pretty much well, but now I will try to do Z-poem, undersaline Z-poem without tunneling. So please show the endoscopic image. Okay, can you see the patient case?
Yes.
Diverticulum. Okay, so this is the diverticulum. It's not too big. It's about 2 centimeters. And this is the esophageal side. I'm using undersaline. Why? It's not obligatory, but when you have minimum space in such patients, it can help you start the procedure. I have placed 2 small dots to guide me for the mucosal incision. I'm using a very slim endoscope, which is particularly useful for third space endoscopy. This is the 840 TP and flash knife. So what I'm going to do, I'm pressing endocut U. I'm working undersaline, and I will do a small incision, and I will try to inject with my knife. Right, so I'm doing the submucosal incision with my knife, you see. And now I start with endocut. I will do a short incision. It's not needed to do a very large one because I'm using a very narrow endoscope.
So you're using flush knife now from Fuji, right?
Flash knife, yes.
Flush knife 2 millimeter or?
1.5.
1.5, wow.
Yes, why? 2 millimeter will be faster, but if you use a knife with a short blade, you diminish the risk of mucosal injury. Now, my strategy is to make a short incision, expose the muscle, and now I have exposed the muscle, and I will not do tunnel. I will inject here at the diverticular side with my knife. I created a cushion. You see the cushion? And now I will inject from the esophageal side. And on the middle, I have the septum. Now I can start. I'm doing the septotomy right now under saline. I expose the muscle fibers. The more we cut, the more space we will have. Now I switch to CO2. I inject again.
So this is very, very unique for you that you do the single tunnel. So you dissect and cut at the same time, George, right?
Yes. Yes. So I published this technique in endoscopy 3 years ago. And then we published our series comparing tunnel-free and standard technique. And we demonstrated that you gain about 10 to 15 minutes if you skip the tunnel.
طيب I will explain to the audience. احنا الزنكر diverticulum عندنا كذا طريقة لعلاجها بالزي بويم. لما بيبقى الدايفرتيكولر كبير ممكن نعمل tunnel on either side of the diverticuli so that I expose the whole septum and then I cut and then I close. جورج هنا بيعمل ايه؟ This is a small diverticuli فهو مش عايز يضيع وقت طويل في ان احنا نعمل tunnel فبيعمل exposure. عشان كده مختار سكينة رفيعة قوي اللي هي 1.5 فتح بالراحة وبعدين he did dissection. هو عايز يحافظ على الميكوزا برضو فبيعمل dissection and he is cutting in the same time. Dissection and cutting of the septum in the same time. This is, we call it like tunnel free Z-poem, and it's also it allows George, can you explain more now?
Yes. So a common question is how deep do we go? So the answer is that we go until at least until the bottom of the diverticulum. So from time to time we have to exit and see if the diverticulum collapses. So here is not collapsed yet. And we can also check from the esophageal side whether the discoloration goes deep enough. But the most important is to see that this muscle becomes thin. So it's not thin yet. So I suppose we have at least 1 more centimeter. This is the transition to the esophageal part of the muscle. I use EndoCut EU because it works well under saline. This is the new current by Herbe. And usually we don't experience vessels, although now I use precise sec.
George, what scope are you using? You're using Fuji scope, right?
Yes, yes. So you can see the type of the scope on the screen at the upper right side.
Which one, the 7 or the 8?
This is the 7.9 millimeter Fuji scope. It's called 840.
Oh,
this is a fantastic scope because it's therapeutic. You have a large channel, 3.2 channel, but it is very slim, and it has also water jet. So I think this is a very attractive scope for third space endoscopy.
Yes, yes. We were just speaking about the new scope from Fuji, about the outer diameter of 7.9 and still a therapeutic working channel. And I did the same case of Z-Poem before, and it was really amazing in the Z-Poem because the space is very narrow.
Very narrow, and the mucosal incision is very small.
I'll come back to you. I will come back to you. Can we go to Iraq, please, Sulaimaniya? We have left Hiwa for a lot of time. Can we shift back to Greece, to Athens, to see the Z-Poem case? We'll come back to you. George, are you still with us? George, can you see us?
Yes, hello. Can you hear us?
Yes.
Yes. So we are at the end of the tunnel. Here the muscle layer is very thin. This is the esophageal muscle, and you can see the extension. It took us 3-4 minutes to complete it because it's a small diverticulum.
And you're using ACI, George.
And now I'm using the ACI mode that illustrates the muscle layer very well. There are no remaining fibers.
Okay.
And now I will evaluate the depth in
George,
2 more
can you
ways.
show the audience the ACI mode again, please? Can you show them?
Yes,
the
so this is a standard endoscopic view. And now I switch to ACI, it's more reddish. And we see the blue very well, and we identify the muscle very well. This is the standard mode, this is ACI mode. So the muscle becomes more white. This is the standard view, this is the ACI view. And the blue is Greek blue, Aegean blue, all right?
Aegean blue, yeah.
Yes.
So
what is the
here
limit for muscle cut, please? What is the limit?
Yes.
Your limit to cut muscle cut.
exactly.
Landmark
So,
muscle cut.
so I extend 1-2 centimeters beyond the bottom of the diverticulum. So this is the bottom of the diverticulum, is already collapsed. And if I enter here, I'm much more deeper. And also from the esophageal side, we see that the extension of the tunnel is very deep. So now we will proceed to clipping. For me, this is the most difficult part of the procedure and the most important. We will start to place the first clip higher, here, close, but don't deploy. I want to check whether the lumen is still open, because one of my few, let's say, adverse events was closing the entrance to the esophagus. So I try to check if I'm well. Actually, now I realize that I can place it a little bit higher. Please open the clip. I will place it a little bit higher. Here, close here. Now I move my endoscope to see if I'm okay. Okay, please deploy.
So what is the type of clip you're using?
This is a conventional clip, nothing special. A generic clip, nothing special. 11 millimeter clip with a not very long stem.
Does it make any difference if you start from the top end or the lower end?
Yes, I suggest you start from the top in order not to obscure the view for the subsequent clips. And I usually place 6-7 clips. I'm very aggressive with the clips.
So
I never had a leak. Yes, please tell me.
So George, do you think that the opening over the tunnel has a lot of advantages because using the clip over the redundant mucosal fold can cause ischemia to the this
Yes.
redundant mucosal? Yes.
Yes, by placing the clips, you also destroy the mucosal flap. I would like to say that for diverticula more than 3 centimeters, nowadays, at the end of the procedure, I also do mucosal trimming. So I cut the mucosa for diverticula more than 3 centimeters.
Okay. Very, very nice demonstration, George. We will come back to you. I know that you have a lot of cases for us. So let's move.
I will complete this closure, and if you have time, I will start an ESD.
Yeah, sure.
Share with us.
Yes.
We'll see you later.
For your ESD, and we'll come back to you. Thank you a lot,
All right.
George. Thank you.
Bye.
Very
Bye.
nice.